thank you very much to the organizer for inviting me. It's an honor to be here, but I'm in a very difficult spot for two reasons. One, because I have to talk after Dr. Swaminathan, who's one of our eco-heroes. And second, because this is the first meeting I've been invited in Europe after I left Europe 13 years ago. So this makes me twice nervous. And the talk I've been asked to give today is about the use of right ventricular strain in the operating room. I won't be as good as Dr. Swaminathan is in make sense of diastolic dysfunction, and he's one of the few people who can actually do that, but I'll do my best. I have to disclose a research agreement with Siemens, but I don't receive any honorarium from them nor from any other vendors. In the next half an hour or so, we'll talk about right ventricular anatomy and physiology, which is something we need to refresh our minds about just to make sort of build our talk about the use of strain. We'll talk about how we quantify currently and according to our guidelines the right ventricular function. We'll talk about strain based on tissue Doppler. We'll talk about speckle tracking. We'll talk about some of the limitations and pitfalls. As we all know, one of the main challenges in assessing the right ventricle, and this actually came out of Dr. Swaminathan's talk before the break, is its geometry. As you see, it's a very uneven geometry, and you need specific software to actually capture the geometry of the right ventricle in its entirety. And depending on how we cut the right ventricle, if we cut it longitudinally, it has a triangular shape. If we cut it during its coronal axis, it has a crescent shape. Not only the shape is funny and very complex, but its physiology is very different from the physiology of the left ventricle. And you can see here that pressure volume loops of the right ventricle, they sit in a tiny little corner of the pressure volume loop of the left ventricle. So it's a much lower pressure system, and it's also a system that doesn't tolerate well the increase in afterload. So there's a significant change in volumes with increase in afterload. What our current guidelines say? So current guidelines are not specific to transesophageal echo. They are in general for echocardiography. And one of the challenges of us in the operating room and those of us who do transesophageal echo is to make transesophageal echo as similar as possible to transthoracic echo in order to reproduce the same type of measurements. And when it comes to assessment of right ventricular function, it's quite challenging. And we've actually used, according to our guidelines, some area measurements. We've used other type of measurements, such as TAPSI, and now technology has helped us make our measurements a little bit closer to what the measurements in transthoracic echo are. Using difficult to obtain transgastric views, or at least difficult for most of our trainees and beginners, we can get alignments to the tricuspid annulus that are similar to transthoracic, although we're not really looking at the same portion of the annulus that transthoracic looks at. We can get linear measurement, we can use tissue Doppler. But one of the other limitations of current guidelines and measurements is that a lot of the numbers that are given and the tables, these are from the latest 2010 guidelines, they're talking about normal and abnormal. They're not talking about the grade of function. And in fact, applying and using most of the measurements, we can say yes, no, there isn't right ventricular dysfunction. So what would be the ideal measurement of right ventricular function? Would be easy to obtain, obviously, reproducible, would be a continuous variable, and hopefully would correlate with outcomes. We were talking about the right ventricular geometry and physiology. We know it's complex, but on the other hand, if we compare actually the muscle structure of the right ventricle compared to the left ventricle, the right ventricle is a much thinner wall that has pretty much just one muscle layers, compared to the left ventricle where we have different bundles or different layers of muscles in the endocardium, mid portion of the myocardium and epicardium. And if we look at